Impact of staff perception using discounting of treatment options, problem behavior management, and restraint usage by Katrina Lenbeck. Autism is a developmental disability with social, communication, and behavioral challenges. It can be difficult to diagnose. The prevalence is now 1 in 59, and it's more common in boys. So the criteria, there needs to be persistent deficits in social communication, social interaction across contexts, restricted, repetitive patterns of behavior, interests, or activities. This criteria can pose challenges in their everyday life and can bring out challenging behavior such as self-interest behavior, aggression towards others, temper tantrums, and noncompliance. Not only does it affect the individual, but it affects the family and those around them. Early identification and intervention is key. Some evidence-based treatments are applied behavior analysis, occupational therapy, speech, and physical therapy. Anecdotal treatments are dietary approaches, essential oils, horse therapy, and those that aren't backed by evidence. And there may be times where restraints are used, especially in like a school setting, when their behaviors can be dangerous to themselves and others around them. With staff, there's not enough time to implement or they don't have the experience with autism, especially if the students are in a school, a classroom with more students. So the children with autism are being placed in like a therapeutic school where they can handle them a little better. Discounting. Impulsivity has been defined by a rapid, unplanned reaction to internal and external stimuli and not having any regards for consequences. And the opposite is self-control, where someone has the ability to control one's own impulses, emotions, and desires. Impulsivity tends to lead to negative outcomes, while self-control leads to putting aside the preferences and going with a choice that is more socially appropriate. Discounting has been linked to impulsivity. So delay discounting is widely used and provides individuals with choices of hypothetical rewards. One reward is available immediately while the other has a delay. There's temporal, social, and probability discounting. Discounting has been used in a wide variety of topics, which include sex, gambling, mental health issues, cigarette smoking, substance abuse, public good games with staff and parents of autism, and in many other areas. There is limited research when it comes to staff who work with children with autism in regards to discounting. Call It All completed a study using parents' perspectives, and they found that parents were more impulsive when it came to treatment outcomes. And then Dixon et al. Completed three experiments using graduate students and parents in the third survey, and they found that those that had experience working and living with individuals with autism had an increase in impulsive decision making with risky choice behavior. So the purpose of the study is to apply delay and probability discounting in areas of treatment options, problem behavior, and restraint usage with staff members. The study is an extension of the previous study by Dixon, Whiting, and Miller by using the Problem Behavior Management Survey and Restraint Usage Survey to see if similar results are achieved. The participants were used in a therapeutic school and an adult day program. There were 31 participants, 30 female and 1 male. Ages ranged from 20 to 75 with a mean of 45.22 and a standard deviation of 11.33. For years employed, it ranged from 1 to 38 years, with a mean of 12.24 and a standard deviation of 9.45. There are 23 employees from the school side and 8 employees from the adult day program. There are 4 teachers, 15 aides, 8 direct support professionals, 2 speech, and 2 occupational therapists. So there were 3 surveys. Survey 1 had 90 questions, while Survey 2 and 3 had 91. A demographic questionnaire was presented, and then the surveys were administered on Google Forms and or paper or pencil, depending on staff preferences. So for the procedure, consent form was presented and then obtained, and if they agreed, the demographic questionnaire was presented, followed by Survey 1. which had a hypothetical statement about treatment options. So choosing the best treatment option as if it was a real situation. Each option represents a treatment used to decrease the problem behavior. So pick which one you'd rather have. You will continue to see two choices. Just continue to pick the option you'd prefer. So option A was the anecdotal evidence, and option B was backed by evidence. Option A started out with 30 minutes and increased to 1 hour, 3 hours, 5 hours, 10 hours, 15 hours, 20 hours, 25 hours, and 30 hours. And option B always stayed 30 hours. For option A, the percentage decreased. So from 100% to 90 to 80 to 70 to 60 to 50 to 40 to 30 to 20 to 10, while option B stayed at 100%. Survey 2 was for problem behavior management. So you were told you were going to work with a child or adult until the end of the year, and to assume that you were going to start working with them directly and they have autism. So you have to choose between two choices. For the first choice, the percentage decreased from 100 to 96 to 80 to 70 to 60 to 50 to 40 to 30 to 20 to 10 to 8 to 4 to 2%. And the second choice increased in the amount of time it took. So 1 week, 2 weeks, 3 weeks, 1 month, 3 months, 6 months, and 1 year. For survey 3, it was in regards to restraint use, and you had to assume that you were at a job site, and you had to put the individual in a crisis intervention restraint, and you select between the options below. So option 1 decreased in percentage, so from 100 to 96 to 80 to 70 to 60 to 50 to 40 to 30 to 20 to 10 to 8 to 4 to 2. And then option 2 increased in the amount of time. So 1 week, 2 weeks, 3 weeks, 1 month, 3 months, 6 months, and 1 year. For the data analysis, there were several visual and statistical analysis used, and difference points were identified at each delay for each participant. They are when the participants switched from the delay reward to the immediate reward. There were 9 delays in survey 1 and 7 delays in survey 2. They were then used to calculate the area under the curve. A hyperbolic discounting functioning was used, and then an R2, or the coefficient of determination, is a statistical measure to see how close the data is to the fitter regression line. It's a goodness to fit measure to determine if the model provided a good fit for the data, and the value is between 0 and 100%. Higher value equals a better fit. So for result 1, the AUCs range from 0 to 0.99. Survey 1 was about treatment options. There was a mean of 0.77 and a standard deviation of 0.31. The AUC levels were high, indicating lower levels of impulsivity and more self-control. The visual analysis for survey 1 through the use of a discounting curve was the exponential function, and that provided the best fit, producing an R-squared value of 0.4156. For survey 2, when it comes to problem behavior management, it ranged from 0 to 0.99 with a mean of 0.54 and a standard deviation of 0.38. The average AUC being between 0 and 1, this suggested that staff were more willing to discount in regards to problem behavior management. So the logarithmic function provided the best fit for this data, and it produced an R-squared value of 0.4356. For survey 3 with restraint usage, it ranged from 0 to 0.99 with a mean of 0.53 and a standard deviation of 0.40. So similar to survey 2, this showed that staff are willing to discount in regards to restraint usage. So for the visual analysis, a polynomial function provided the best fit, producing an R-squared value of 0.3498. The purpose of the present study was to investigate how school staff and direct support providers evaluated delay hypothetical treatment options, problem behavior management, and restraint usage. The results didn't fully support the current research. They were less likely to discount, so resulting in lower levels of impulsivity. So limitations, the male to female ratio was a limitation. They weren't equivalent. Future research can make sure the sample size is equally representative of male and female employees in the profession. Another limitation was depending on the staff's job. Some staff were exposed to the students longer than others, and future research can evaluate how different professions discount student problem behaviors as well as their engagement in restraint usage. Another limitation was self-reported measures. So future research could address this issue by having an unknown researcher implement the discounting task to reduce the risk of reactivity. Another limitation was using hypothetical scenarios versus real-life scenarios. So future research could evaluate real-life events related to treatment options, problem behavior management, and restraint usage, and seeing if there's a correlation between that and the discounting task. Another limitation was utilizing staff from a school and day program could also be a limitation in the sense that treatments, problem behavior, and restraint usage would vary from working with children in a school to working with adults in a day program. Future research could address this limitation by sampling staff that engage in restraints frequently versus those that don't, and compare the differences in the discounting task. And then another avenue for future research could use a wide variety of districts who work with children with developmental disabilities and autism. So not only would problem behaviors and severity of disabilities range, as well as the range of disabilities vary for each school district, the school's procedures in handling problem behaviors could possibly be different, resulting in dramatic differences in discounting rates. So the literature regarding discounting is vast, yet there's a lack of research related to staff in working with individuals with discounting disabilities who engage in problem behavior. In this study, staff are less likely to discount. So with the limitations and the future research, more studies can be completed to see if there are more impulsive discounting